Good afternoon. Myself, I am Dr. R.V.L. Gowthami, Consultant Interventional Cardiologist at KIMS Kondapur Hospitals. Today, I would like to talk about heart failure, which is a very common entity seen in India. So, I would like to describe all the symptoms that the patient has for when he presents with heart failure, and also the what are the management strategies for this condition. So, what is principally heart failure is it is a pump failure, which is because there is a defect in the contractility of the heart. So, the contractility of the heart declines, and the patient presents with heart failure. So, there are different types of heart failure like acute heart failure and chronic heart failure. Acute means a patient suddenly who was asymptomatic before has suddenly landed up with symptoms of heart failure. So, what is chronic heart failure? Chronic heart failure is a condition wherein the patient tends to have symptoms from a long duration of period, and he tends to have slowly acute exacerbations, which we call suddenly the patient develops more symptoms for which he will require hospitalization, ICU admission, and necessary injections. So this is one type, and the other types are like right heart failure, left heart failure. So we all know principally there are four chambers in the heart, and there is right heart and left heart. So right heart essentially carries impure blood, say desaturated blood, and left heart has pure blood, from where the blood is pumped by the left ventricle into the aorta, which is the major blood vessel in our body, and from there the blood is circulated to the entire body. So this pump mechanism by the left ventricle is very essential for the all the organs in the body for proper functioning and blood supply. So when this fails, we call heart has failed. So LV failure. Sometimes RV, that is right ventricle failure, can also present with a myriad of manifestations like decrease in the pulmonary blood flow. So from right ventricle, the blood flows into the pulmonary circulation, and from left ventricle, it goes into the systemic circulation. So when systemic money, it is pure blood which is coming to all the organs in the body. So when the left ventricle fails, there is some set of symptoms with which the patient presents, and when the right ventricle fails, there is another set of symptoms. Okay, so I will be describing all these symptoms. And you have another thing like forward heart failure and backward heart failure. So when the blood is not going forward from the left ventricle into the aorta and the rest of the body, the blood tends to accumulate in the lungs, which causes symptoms of breathlessness, sudden onset breathlessness, the patient, and what we call paroxysmal nocturnal dyspnea, which means the patient will not be able to lie down without breathlessness. So he will be very breathless to lie down, and patient will not be able to sleep in a horizontal position. That is called paroxysmal nocturnal dyspnea. So when the left heart fails, patient principally tends to have breathlessness, initially in the form of like breathlessness on mild and moderate exertional work. And when the LV fails maximally, the patient will not be able to remain breathless without even at rest. So he will have breathlessness even at rest. And you have, when the patient's right heart fails, the blood tends to accumulate within the body. That is systemic circulation, we call. I mean, systemic venous congestion, we call. So, which means the patient, when the right heart fails, the patient has principally symptoms of pedal edema, which means both the lower limbs will get swollen up. So, there is swelling of the legs, there is abdominal distension. The patient's abdominal girth increases, and because of this also the patient will have breathlessness. So these are the principal signs of right heart failure, which is bilateral swelling of lower limbs, abdominal distension, and the principal symptoms of left heart failure are breathlessness on exertion, and also inability, orthopnea, which we call inability to lie down without breathlessness, and severe breathlessness at rest. So these are the principal symptoms with which we see a patient of heart failure. So these patients of heart failure, whenever they have symptoms, they reach the hospital for further evaluation. So then we do a couple of investigations, and we first initially diagnose this condition in the patients. And the principal investigations are depending upon the age. For elderly patients with risk factors like hypertension, diabetes, we usually order an ECG and then followed by 2D echo to see how are the parameters of the heart. So in ECG, we may pick up any undiagnosed heart attacks, means myocardial infarctions, which we call. So each ECG may show that changes, which means that one of the blood vessels supplying the heart has been blocked, either suddenly now or pre-existing already, which was undiagnosed or unnoticed by the patient, and now the patient is presenting with long-term complications of the coronary artery disease. So ECG may pick up such things, and also ECG picks up any increase in size of the heart, which we call heart enlargement. So all these things will be picked up by the ECG. And then we go for 2D echocardiogram, which means a detailed structural and anatomical functional condition of the heart will be seen in the 2D echocardiography. In this, the most important parameters are the volumes of the heart, that is the size of the heart, whether heart is a normal size or it has enlarged by the time the patient has presented, which will be very important in the prognostication of the patient's condition. And the other important parameter that we would like to look for these patients is the ejection fraction. Ejection fraction is the parameter which speaks about how well is the ventricle pumping the blood out of the chamber into the major blood vessels of the heart for peripheral circulation. So EF, which we call routinely. So the normal range for this EF is 54% in males and 52% in females. So anything less than this we call LV has failed. So the principally EF means we are talking about the left ventricular ejection fraction. So the efficiency of the ventricle to pump the blood into the peripheral circulation. If this EF declines, then we call systolic heart failure, or say heart failure with reduced ejection fraction. So the other subset of patients where patient will have heart failure symptoms, the said symptoms that I have told now, breathlessness, paroxysmal nocturnal dyspnea, orthopnea, all this. Patient will have these symptoms, but still the patient's EF will remain well above 50%. These are the set of patients whom we call heart failure with preserved ejection fraction. So this is a newly diagnosed entity which is increasing these days more with obesity, aging population. Even without decline in heart failure, EF, there are heart failure symptoms in these patients. This is because of mainly the heart muscle has lost its accommodative capacity, we can say. So which means that it will result in symptoms of heart failure because it is not able to take up any amount of blood that is coming into the ventricle from atrium. So all the blood tends to remain within the pulmonary circulation, and the patient has these symptoms. Inadequate relaxation of the ventricles is what we call. So these are the subset of patients in heart failure with preserved ejection fraction. There is another recent upcoming term which is called heart failure with mid-range ejection fraction, which means the patient is having heart failure symptoms and the EF is in the range of 40 to 50. Okay, less than 40 is reduced ejection, more than 50 is preserved ejection, and between these two is the mid-range ejection fraction. Principally, all these three groups of patients will have heart failure symptoms. So this is one important investigation that we order. And we also order a couple of blood investigations also to see other organ uh, functions like renal function test, liver function test. We also would like to check for reversible causes of heart failure. Principally in Indians, chronic anemia also causes heart failure symptoms. So if a patient is found to be having low hemoglobin and heart failure symptoms, correction of his hemoglobin with blood transfusions and iron supplementations will also improve the ejection fraction that we are talking about and improvement in heart failure symptoms. So it is very important to look into the correctable causes of heart failure. So we also need to look into other vitamin levels like vitamin B1, thiamine deficiency, B12 deficiency, iron deficiency. All these deficiencies should be corrected in a patient presenting with heart failure. So after going through this set of investigations, we will like to see for the need of admission into the hospital for this patient presenting with symptoms, whether he can be treated on OP basis or whether he will require inpatient admission. So inpatient admission for heart failure is usually required when the patient is very much breathless at rest. He is not able to lie down. He's not able to sit. Then, which means that he will require oxygen support and also require injectable medications, which are called diuretics, for sending the excess fluid that is present in the body through the urine. So these are the necessary most important things where the patient will require inpatient admission. So all other patients who do not have this decline in oxygen and need for hospitalization can be managed on outpatient basis. So now we will be looking into what are the possible types and causes of heart failure. So one most important cause in our setup is coronary artery disease. So coronary artery disease, as I said earlier, is about the block in the major blood vessels supplying the heart. So when one of these blood vessels tends to block, the patient the heart muscle is damaged and there is a decline in pumping capacity of the heart, which results in heart failure with reduced ejection fraction. So over a period of time, if the patient goes unnoticed, then he may land up with ischemic cardiomyopathy. This is called ICMP most commonly. Okay, and other condition is dilated cardiomyopathy, which is because of so dilated cardiomyopathy is a condition wherein the patients have genetic deficiencies, which results in abnormal muscle contraction of the heart, and which will cause dilated heart over a period of time, and the patient may present with heart failure. So this is a genetic cardiomyopathy which usually presents in the form of dilated cardiomyopathy. The heart chambers enlarge and the patient presents with symptoms of heart failure. There are several other forms of cardiomyopathy like restrictive cardiomyopathy and infiltrative cardiomyopathy, which is because an abnormal protein gets deposited within the muscle of the heart, which leads to set of heart failure symptoms and improper functioning of the left ventricle or right ventricle, depending upon where the protein has deposited, and this leads to set of heart failure symptoms. So it can occur in elderly population or the middle-aged population. So cardiac amyloidosis is one such condition which leads to restrictive cardiomyopathy. So you also have cardiac sarcoidosis, which causes restrictive cardiomyopathy. So these set of cardiomyopathies can be diagnosed with the help of MRA, cardiac MRA. And also sometimes endomyocardial biopsy is required to diagnose these conditions. So we have another cardiomyopathy which is called hypertrophic cardiomyopathy. This is also a genetical cardiomyopathy wherein the patient's heart muscle tends to deposit fibrotic collagen and there is dense scarring within the myocardium, which results in a set of conditions of heart failure. And also this hypertrophic cardiomyopathy, which is routinely called HCM, will result in obstructive valvular heart disease. So it is exactly not subvalvular, but subvalvular, not valvular, but subvalvular, which means because the heart muscle is hypertrophied, which means it has increased in size, the patient tends to have obstructive symptoms. There is no adequate flow of blood from left ventricle into the aorta because of the enlargement in the muscle wall. So left ventricular wall gets hypertrophied. This causes set of symptoms in these patients. So it is a very important condition which is to be known to all of us because these patients may have very high incidence of sudden cardiac death. So some of the patients we hear who are normal well before the death, so they were thought to be healthy but still have had suffered a sudden cardiac arrest. So a subset of these group of patients may be hypertrophic cardiomyopathy patients because they have very high incidence of arrhythmias, which means the heart rate suddenly increase very high, up to 200 beats per minute. When the heart rates are so high, the blood pressure tends to drop and the patient has sudden cardiac arrest. So this is one cardiomyopathy which can present with sudden cardiac arrest in young persons. So, a family history of sudden cardiac death is very important whenever you see a patient of heart failure. So, or say hypertrophic cardiomyopathy. These patients will require further therapy and further investigations to evaluate the risk of sudden cardiac death. So, other causes of cardiomyopathy, which we see very frequently in our country, is in females, young females. Peripartum cardiomyopathy, this is called. So, what is this peripartum cardiomyopathy? This is seen in pregnant females in their last trimester of pregnancy, which means the last 3 months of pregnancy, followed by during delivery, and then up to 6 months after delivery. So, a pregnant female who has presented with breathlessness, sudden onset, or slowly progressing in the last 3 months of pregnancy, during the delivery, and first 6 months post delivery. If there are symptoms during this period, we must give very high probability and suspicion for peripartum cardiomyopathy. So, a 2D echo investigation in these patients will pick up a reduced ejection fraction, which is usually less than 45%, which has caused these symptoms in these females. So, it is very important that we correctly manage, because we are dealing with two two parameters, like we are dealing with the mother and the child also. So it is very important to adequately correctly manage these patients, and the most important thing would be to manage the fluid restriction in these patients and also give appropriate therapy till the term of delivery and also following delivery. And the most important thing is, it is almost to the incidence of 1 in 1000 live births in India, whereas in the Western countries, it is up to 1 in 4000 live births, which means it is very high in prevalence in India. So we need to carefully look into this population and the recurrent pregnancies. So in the second pregnancies also it may repeat. So we usually advise avoiding pregnancy till the ejection fraction becomes normalized in these subset of patients. In case if the ejection fraction has not normalized after the first episode of peripartum cardiomyopathy, we usually don't recommend pregnancy because for the pregnancies, because it is a very high risk condition for both the mother and the child. In case if the ejection fraction improves over a period of time to more than 50%, so after 3 years, the patient can plan pregnancy under the supervision of an cardiologist, which is very important to give the necessary medication. So the patient has to be on the cardiac medication for a long term so that there will not be any recurrence of peripartum cardiomyopathy. So these are some important cardiomyopathies which we see. And also there is another infectious entity called myocarditis, wherein you see a patient who has developed high grade fever, viral fevers, and suddenly has a sudden onset of breathlessness after 3 to 4 days of fever, which could be that there is a very high probability that the patient has suffered myocarditis. And also you have cardiochemotoxic drugs, that chemotoxic drugs which present with heart failure. So we see a very high prevalence of cancer these days. So there are chemotherapies being administered for some cancers like breast cancer, blood cancer, and all. So these cancers are treated with chemotherapeutic drugs, which can cause acute and chronic effects on the heart. So acute effects in the form of rhythm disturbances, and chronic effects in the form of decline in ejection fraction. Whenever there is decline in ejection fraction, the patient will present with pump failure symptoms, just as I said before. So this is also a very important entity. So a patient, like say cancer patient on chemotherapy, if he develops breathlessness over a period of time slowly or acutely, which means suddenly, so he has to get his 2D echo done in order to look for the ejection fraction. So these are the various types of cardiomyopathies which can present with heart failure. Now coming to, we have seen the symptoms, we have seen the investigations which are necessary, we have looked into the causes of heart failure, and we have seen that we need to correct the necessary causes. Now let us see what are the medications that are usually prescribed for this heart failure. So the most important things are the diuretics. So diuretics are a set of medications which are given to reduce the volume overload in the left ventricle. So we understood that the left ventricle is not able to pump blood adequately from the chamber into the aorta, which is to be supplied to the periphery because of defect in the muscle. The heart is not able to contract properly. So we should not overload the heart. So we should empty the heart of some of the volumes so as to reduce the burden. This is the main motto of using diuretics in heart failure. So the excess fluid from the body will be removed with the use of these medications. The same medications, if the patient is having class 4 symptoms, we call, which means the patient is very breathless at rest and he is unable to lie down. Those patients will require admission and we use injectable forms, and those who can be managed on OP basis, we give them tablets, oral form. So these are the important medications for the patient with heart failure. Another set of medications include the remodeling drugs, which include the ACE inhibitors and ARBs, and also the new upcoming class of ARNIs. So these set of medications are principally addressing to decrease the afterload on the heart. So whenever the afterload of the heart increases, the heart has to pump against it. So we reduce, means the vessels in the body are maximally dilated, so that there is no um, peripheral resistance against which the heart has to contract. So these are principally called the remodeling drugs. Means there is a damage in the heart muscle which has caused the spectrum of heart failure. So we are trying to reverse the pathophysiology of the heart failure with these drugs. So by blocking the RAS system and using these drugs, we are attempting to reverse the damage that has occurred in the heart. So very well, we see that very often the patients who are put on these remodeling drugs have a significant improvement in the ejection fraction and they tend to do very well. These are long-term medication that has to be used in a patient with heart failure. The other set of drugs that we use are the rate controlling agents. So whenever the heart is not able to pump properly, we have to reduce the load on the heart, and also we have to reduce the working capacity, we have to reduce the work of the heart. So which is done by reducing the number of times that the heart has to contract. This is principally the motto of using the rate control agents, which are the beta blockers and the other group of drugs, which will tend to reduce the heart rates and the number of times that heart has to contract, and thereby effectively reducing the workload on the heart. The other group of medications that we often use include the antiarrhythmics. Sometimes the heart failure patients, if their EF ejection fraction declines to almost less than 35%, they tend to have ventricular tachycardias, ventricular fibrillations, which means the heart rates are very high, more than 200. So these set of patients will require antiarrhythmics, and if the antiarrhythmics are not working, then we advised devices for the control of heart rates to prevent sudden cardiac death in these patients. These devices include the ICDs. ICDs are called defibrillators. So defibrillators, which means whenever the heart rates are very high, say in ventricular tachycardia and ventricular fibrillation, we usually administer shock from externally using the paddles, as most of us would have seen it. So the same process will be done immediately from a defibrillator, which is placed within the heart chamber. This is called an intracardiac defibrillator. Okay, this is done to reduce the incidence of sudden cardiac death in these patients, heart failure patients, with reduced ejection fraction to as low as 35%. they have very high chances. That's why we use ICDs only in those patients with EF less than 35%. And the other devices that we often use in these heart failure patients include the CRT, which is a cardiac resynchronization therapy. So, some of these patients of heart failure presenting with heart failure tend to have abnormalities in their ECG in the form of left bundle branch block. So, which we say the QRS duration is more than 150 milliseconds. So, whenever there is left bundle branch block in a patient of heart failure with reduced ejection fraction to as low as 35%, and still the patient is having symptoms despite using all the above said medications, we advised CRT for these patients in order to improve the heart failure symptoms. There is significant improvement in EF when all these parameters are met and the patient is offered a treatment of CRT. A significant improvement in ejection fraction is noticed, and also the patient has improvement of his symptoms. The other devices that can be used in these set of patients, heart failure patients, are the IABPs. These are high requirement in those end stage heart failure patients. That is the IABP in ICU setting. Whenever the patient with heart failure is not improving with any medications, then we use this intra-aortic balloon counterpulsation, which is called IABP. All these are done in ICU after admission only. So other group of devices include the LVADs, which means left ventricular assist devices. So these are the set of devices which are placed in the heart chambers, principally the left ventricle. This is done through the open heart surgery, and the patient with heart failure who is undergoing this LVAD is at a very high risk, but still has to undergo the operation to tide over the symptoms of heart failure. So it will be done through an open heart surgery, and this device will be placed within the heart chamber, principally the left ventricle. So we call it a left ventricular assist device. And from there, this device will help the blood to be propelled from the left ventricle into the aorta for circulation into rest of the body. So these are called the left ventricular assist devices. So they can be used as either bridge to destination therapy or bridge to transplantation. If the patient's heart failure symptoms are expected to recover within 1 month, then we put the patient on these devices, left ventricular assist devices. If the patient's heart failure is refractory, the patient is not going to improve. If we see that he is not improving, assisted. So we subject this patient, given the fitness, we give them an option of heart transplantation as the end resort for these patients. So the other important thing is we have initially these patients, we have to see the possible options of heart transplant in these patients. So heart transplantation, it requires donor and recipient matching criteria. So a number of criteria should be met, and the patient's life expectancy should be more than 1 year. Then only we see the compatibility of these two things, and then decide the patient whether he can go for heart transplantation. So that is the end stage. And when in some patients who also have very high pulmonary pressure, say we call pulmonary hypertension or pulmonary vascular resistance, when this is very high, then the patient should be ending up with heart lung transplant instead of only cardiac transplant. These patients who will be subjected to heart transplantation will be put on immunosuppressive therapy for lifelong, like any other transplantation. So they must be put on immunosuppressive therapy and must be in constant follow-up of a cardiologist. So this is the spectrum of heart failure we see. So it is very important for us to understand that whenever we see a patient of heart failure, it is important to correct the reversible causes of heart failure and then look upon to see the how the ejection fraction is improving in these patients of reduced ejection fraction, and how the symptoms are reducing with therapy in the other subset of patients. So this is principally regarding the heart failure. Thank you. Yeah. Okay.